What's going on, everyone? This is Troy and Jared coming at you with another Flipping the Classroom project. Today we're going to be talking about hypothermia and pericarditis. The first thing we're going to be talking about is the pathophysiology of hypothermia. So when the heart becomes hypothermic, there's a decrease in depolarization of the pacemaker cells, resulting in a bradycardia. There's also a decrease in mean arterial pressure and cardiac output, and this may result in a J or Osborne wave in the ECG, which we'll look at later. Also might find some junctional and ventricular dysrhythmias, as well as ventricular fibrillation and asystole can occur in extreme cases of hypothermia when the core temperature is around 25 to 28 degrees Celsius. Some comorbidities along with hypothermia would be alcoholism, sepsis, hypothyroidism, hypopituitarism, and this you will tend to find in indoor hypothermia, which is hypothermia that occurs indoors when it is either cold or someone falls on a cold floor. This may induce hypothermia. When it comes to hypothermia, the mortality rate is not very high. It's about 12% among inpatients. But when we break it down into classifications of hypothermia, we can see it a little bit better. So with mild hypothermia, there is a very low, if any, mortality rate among those inpatients. But when it comes to moderate hypothermia, we tend to see about a 21% mortality rate. And then when we get up to severe hypothermia, we see about a 40% mortality rate. Some signs and symptoms that someone may have hypothermia would be shivering, slurred speech or mumbling, slow, shallow breathing, a weak pulse, clumsiness or lack of coordination, drowsiness or very low energy, confusion or memory loss, loss of consciousness, bright red, cold skin, and that you're going to tend to see in infants. When it comes to treatment and management of someone who has hypothermia, obviously the number one thing we want to do is prevent further heat loss. So this can be done through many ways. If you're not in or don't have capabilities to give them a warm saline solution, you can give them warm blankets or heat pads, remove the wet or cold clothing. But after that, you want to make sure that you are handling the person with care. If you tend to get jerky with them, it could cause them to go into ventricular fibrillation. If that does happen, then we do want to initiate CPR or defibrillation. As far as medicinal use goes, you can administer amiodarone, which helps with heart dysrhythmias, and then a last-ditch effort could be cardiothoracic bypass. Alright, so what you might see on the EKG with someone who has gone into hypothermia, one of the things you may see is what is called shivering artifact. It's just not giving you a good showing on the monitor because the person is going to be shivering so much. As far as the rate goes, as we talked about before, you're going to see some bradycardia. The PR intervals may occasionally be greater than 0.2 seconds. The QRS complex may be occasionally abnormally wide and greater than 0.12 seconds. And then the QT interval may also occasionally be prolonged. And then the last thing you may see are what is called Osborne waves or J waves, which I will show you in a later example. Okay, so here is a good example of what an Osborne wave would look like. And it's also sometimes referred to as the J wave or J deflection or camel's hump. And as you can see at the end of the junction of the QRS complex and the ST segment, you can see that positive inflection there again, and that is what is called a Osborn wave. Alright, and here is an example of a hypothermic patient that has a prolonged QT interval. As you can see in leads 1 and 2, it's very evident there. You can see that the distance between the Q and the T is greater than 0.2 seconds. Here's a good example of shivering artifact in a hypothermic patient. You can see it in leads 1, 2, and 3, and then you can also see it in the augmented leads. You can see that it almost looks like an atrial fibrillation there, but that is actually the shivering artifact. So now putting it all together, this is what you might see in a 12-lead EKG of hypothermia. This is showing you a lot of the classic features of someone that may have hypothermia. As you can see in lead 2 on the bottom, you can see that there is bradycardia. In V4, 5, and 6 is a good example of showing you what those Osborn waves are going to look like. And then in lead 1 as well as V1, you can see, and even lead 3 shows you a good amount of some shivering artifact.
All right, thank you, Troy. Next, I'm going to talk about an inflammatory disease called pericarditis, which is just inflammatory disease of the pericardium. All right, so some goals for this section. I want you guys to gain an understanding of what pericarditis is and the associated comorbidities. And then we're also going to go over the ECG and what to look for. And then we're also going to go over some warning signs and the symptoms and possible treatments for this disease. All right, so what is pericarditis? Well, basically it's the inflammation and swelling of the pericardium, so that membrane that lines the heart. So this could be from an infection or some friction caused from the sac-like tissue. There's supposed to be some fluid in between the heart and the membrane, and those rub up against each other, making you have some pain. So infections, it could be viral, bacterial, fungal, or other means. Or maybe this was due to a previous heart attack, or maybe you're taking some blood thinning medications. This affects all ages and genders, but typically you're going to see an increased risk for males between the age of 20 and 50, and it varies. It may be chronic or acute. Recovery time is actually pretty quick. It typically goes away on its own, so it could be days, maybe even a month, and like I said, just clears up on its own. Maybe some drugs might help. All right, so now I'm going to talk about the signs and symptoms of somebody who's experiencing pericarditis. So typically people are going to experience a sharp piercing chest pain, so kind of like a knife, kind of in the center or the left side of the chest, which is generally more intense when the patient is breathing in. They're also going to have heart palpitations and shortness of breath, especially when they're incline. And they're also going to have fatigue and fever. All right, so now I'm going to talk about some possible treatments for someone who's experiencing pericarditis. Like I said before, rest is typically the best possible treatment you could have because it goes away on its own. They might prescribe some anti-inflammatory drugs, or for dealing with that sharp pain, they might end up recommending that you take some non-prescription pain relievers like Advil. And then something else they might do is they might give you some colchicine. So this can reduce the length of the pericarditis symptoms and decrease the risk of that condition, and hopefully it won't recur. And then something else they might do after that doesn't work, it's a last resort, they might give you some corticosteroids. And then if you happen to be hospitalized for this, you might have to do a periodectomy or pericardiocentesis. So a periodectomy, or yeah, a pericardectomy, that's where they're gonna actually remove the pericardium because it's like too rigid, and they're just gonna hopefully replace it. Alright, so now I'm going to dig into the ECG characteristics and pathophysiology. So first off, the site of origin is going to vary. Basically wherever there's going to be more friction in the heart, or depending on where exactly that infection is going to occur. The rate, it also varies. You can have this pretty much with any sort of heartbeat, although I have seen it's more with tachycardia, just because your heart is working to kind of keep that beat going. And then regularity, it's actually regularly irregular. Typically what you're going to see with this that I noticed was you're going to have PR interval depression, and you're going to have an ST elevation. So if you want to see a good example, I actually provided a YouTube clip below. The guy does a great job of explaining it, and I hope you click on it. Alright, so now I provided you some examples. So what we're noticing on here is we're going to see that widespread concave ST elevation, and you're also going to notice the PR depression, which is present in V2 through 6, and then also those limb leads are going to have it too, so the 1, 2, AVL, and F. There's also reciprocal ST depression and PR in the AVR as well. Alright, so this is kind of like another good example. You're going to see that widespread concave ST elevation and that PR depression. You can see it really well in lead 1, 2, and 3. And then you're also going to see the reciprocal ST depression and PR elevation in V1 and VR. Alright, so this is the final example. Again, you should be noticing that widespread concave ST elevation and the PR depression. You'll also see that the ST depression and PR elevation in lead 1 and AVR.
Alright, and that's everything we got for you. Thanks for tuning in to another episode of Flipping the Classroom with Troy and Jared. See you next time.